Lara Shirikjian. I'm a psychiatrist in the Los Angeles area. I'm primarily a clinical researcher working for clinical trials with CenXL as medical director and principal investigator. And I have a small private practice as well. You know, it depends on the type of practice that you have. It depends on the patient. It's always dependent on the patient. The one thing I would say is it depends on how, like when I mentioned how it depends on your practice. So my practice is a little bit more concierge in a sense, where I have patients that can utilize their insurance or they don't utilize their insurance. So we have more freedom to do things that aren't dictated by, you have to do this first and then you have to do this and do this that's dictated by insurance. Most patients, however, do have to go through an insurance program. So in that case, obviously if there's limitations there, first line, second line treatment, whatnot. The beauty is though, that you can write letters and you could submit prior authorizations and things like that to say, you know what, this patient would really benefit from this for X, Y, and Z, and these are the reasons. And so you can get a little bit more creative in your approach early on. Before, and the way not even before, what we're doing now is we're waiting really a long time before we try any of these alternative therapies and modalities. We pretty much start with, we're gonna start with an SSRI, and then we're gonna do another SSRI, and then we're gonna do another SSRI. So that pattern isn't really working. So now we're looking at different patterns, different approaches, and looking at maybe we should start earlier with some of these different and newer approaches. It's interesting, in a theoretical world, it's one thing. In the real world, it's another. So we do tend to be a little bit more tolerant in patients and have more patience when things aren't working right away. But the data has shown that even within the first 2 weeks, if you aren't starting to see improvement, those remission rates, the relapse rates are gonna be much more tilting in the favor of not helping the patient than they are. And there's been multiple meta-analyses looking at this. So I think you should see some movement on the dial within the first 2 weeks. And if you don't necessarily have to abandon the ship, because you do wanna do a proper treatment period of time with the therapeutic dose. You do want to follow the protocol and the rules there, but within the time frame of what therapeutic dose at the minimum required amount of time, if you aren't seeing improvement, then don't wait for a miracle and shift. And this is easier said than done, because sometimes I'm like, let's just give it a little bit more time, but evidence has shown that that's not necessarily the case. So I'd say you can kind of get a glimpse within the first 2 weeks, and it also helps with the buy-in from the patient. Because if they don't see that they're getting better, they're not going to get better, right? They're going to stop doing things that they should be doing that also will improve their health, like their routines or exercise and sleep properly. They're just kind of falling deeper into the pit. So that buy-in and that early intervention and the early treatment really helps with the long-term outcomes. I would say don't be afraid to try something that you haven't tried. Look into it. I'm not necessarily saying you have to jump from only prescribing medications to all of a sudden doing vagal nerve stimulation. You don't have to go to the extreme, but you can educate yourself, you can refer out. I think that's important too. I do that. If it's something that's not my field of expertise or I'm not comfortable with, I'll refer out and then say, okay, you're just gonna, for example, if I'm gonna do esketamine, I'm gonna send them to a treatment center. I'm not a treatment center, I don't have a treatment center, but I can refer out to a program that's gonna do that specific treatment for them with esketamine, and then I can still monitor their antidepressant, oral antidepressant, and monitor them or do therapy or whatever it is that's for that specific patient, and to know what my strengths and weaknesses are. You don't have to do everything. You don't have to sign up for everything, but you could still utilize these services by referring out. Because a lot of people are like, I'm just gonna stay in my lane and do your thing. I'm not trying to poach your patient. I think there's a fear of that, especially early on career. They're gonna come in, they're gonna go, and that's fine. That's the patient's choice. Intense. The title of it sounds intense. Interventional, almost like you're gonna do something abrasive or more risky or harmful, but that's not really the case. It's just intervening at the stages where you feel like I need to intervene, I need to do something different. I'm gonna do a different type of treatment that may not be an antidepressant, for example, like the typical ones that we've been using. We've got such great evidence with electroshock therapy or ECT, that's what we were calling it before, and there's such an aversion to it, it's so controversial. And I think people automatically think to things like that, the stigmas that have been carried with it over the past few decades. And there is a place for it. And so it's not for everyone, it's for specific people. But we also have to feel, again, it's specific to the patient. And that's what we're doing. It's more, interventional is a good word, but I think like a catering type of, I don't know what the better word would be, but you're really catering to your patient and what their needs are. I guess it would be anything that's not what we're normally doing, right? Which is switching from one oral antidepressant to the other. I think anything else then should be considered interventional, especially if you're doing something early on where you feel like, well, is this what I'm supposed to do? But if you're following the label, right? If you're staying within the FDA guidelines, you have your safety net, you're there. So you're not at fault for trying it, you know? So it's anything, that's how I see it, is if it's indicated for something, you're staying on label, go for it, even if it's outside of your comfort zone.